Welcome to the webinar, the four-step pre-surgical implant protocol, clarity versus surprises. It is a lecture being presented by Jeff Carlson, CDT, and we will begin shortly. And now it is my distinct pleasure to introduce Jeff Carlson, CDT, our Senior Implant Specialist. Mr. Carlson has more than 40 years of experience in dentistry, including nearly 30 years focused on dental implants. His career is focused on education, clinical protocol development, and product innovation for full arch reconstruction on both national and international levels. As Senior Implant Specialist for NDX and Sequence, Mr. Carlson provides technical chairside support and lectures nationally and on immediately loading full arch restorations, NDX and sequence guided prosthetics, and advancements in full arch implant technology. And with that, it is my honor to say, take it away, Jeff.
Thank you so much, Jessica. That's why we have 2 hours. Hey, everybody. Thank you so much for joining. I really enjoy this and look forward to sharing some information with you. This isn't the first time I've ever presented it. It's the first time that I've organized it in such a way that it's what I've been actually sharing and doing for probably pushing almost 30 years with this four-step pre-surgical implant protocol, if you will, or implant process. And so I'm really excited to share this. I don't think I've ever done this on a webinar before. I've done it in my personal live presentations. A lot of the information, I just don't see it out there. And I believe my experience has been that it's what I use almost any time I'm involved with cases, this process to one degree or another. So let's get right into it. I do have to do my quick disclosures. I'm a full-time employee of NDX, National Dentex, and I'm being paid for my time. And commercial support, again, they're providing me the information, the slides. Brands are just used as references. And here we try to be generic. Some topics are hard to be generic, so you'll see specific brands. I try to do more than one to give different, to be not biased to anyone in particular. So our learning objectives, because I think this is really important. For me, it's really important when I'm wanting to go to a lecture or a presentation. You're going to be very comfortable with this simple, straightforward four-step pre-surgical implant protocol or planning protocol. And really, a lot of it has to do with communication and where pulse checking yourself of, has this been done yet? Has that been done yet? That helps to prevent the surprises. Doing this a very long time, maybe you could also think to yourself how many surprises that you've had when you're beginning to work on a patient, seat of restoration or whatever, and you have a surprise. They're usually not good surprises, right? They're usually the surprise, and you're like, I don't really like surprises unless they're good ones. So my goal really is to help to really bring clarity to this topic and this process and to try to help minimize surprises. No one can eliminate them. No one can eliminate the variables and all those different things. I think the best we can do is we can all attempt to minimize any of the negativities. And then I really got some very good key points that have the data backing it up, as well as just personal experience, other clinicians' experience as far as critical clinical and technical considerations. And it's still everything we're talking about tonight, right there, the last two words on the slide. It's really about patient focused, patient centered, about their goals, about why are they doing this. So why could be asked just of me as to why a four-step pre-surgical process. Clarity, I'm big on clarity. I looked up in Webster because I was curious, and it said the state of having a full, detailed, and orderly mental grasp of something. Those are not my words, that's the Webster Dictionary. And I really am about orderly, and those that you know me, my time within Sequence, I've always said it's a great name for the product in the procedure because it's in sequence, step by step, very orderly. And then I looked up surprise, and not that I don't know what that is, but here again, I thought it was interesting. Not my words, Webster Dictionary, the feeling caused by something that is unexpected or unusual, but unexpected seems to be the one that gets us the most, right, in our day-to-day activities. The other thing about what I'm going to be sharing with you, we talk about treatment complexity. But the idea is that the more that gets involved in the case, and you really, it's not just about the number of implants. You can have a complex single unit case. It could be a lot about complexity, very high patient aesthetic demands, extremely high. It could be deficient bone, tissue, both. It could be occlusion. It could be a lot of things to make it complex. So I think the point of what I liked about this slide was that it talks about when you start feeling yourself getting into a little more complex issues, or here's another thing, something else and something else, you begin to wonder, oh my gosh, am I biting off more than I can chew? And really, I think it really means that you have to sometimes slow down, back up, and just go back to really what I'm going to share with you, these 4 steps. And I really hope that you'll find that it'll help you. It has helped me over the years and helped many people that I've worked with. So, what are these 4 steps to this pre-surgical implant process? And the key is pre-surgical because once the implants are placed, whoever did the placing of the implants, be it the restorative doctor, if you're also the implanting clinician, or if you're the restorative doctor referring the patient to a specialist, an oral surgeon, a periodontist, or whoever, that once those implants are placed, they say you're married to the patient. They have an expectation of meeting their expectation. And you sure hope that you and the team involved are aware of what that expectation is and can define it, and very importantly, be able to meet that expectation. And therein lies the challenge. This is pre-surgical. No implants have been placed. This is the due diligence to help make sure that your case, that you do have clarity through the process and minimize the surprises through the process. So these are not new words to any of you. Patient expectations, restorative options, basic biomechanics, the team concept. What I think might be new to many of you, and what I've been utilizing for many years, is what does that really mean? And then how do you tie them in, the 4 steps, into each other? Because they are interwoven completely, and you cannot do any of them without the other ones. So patient expectations, the way I've defined it, is it's what the patient, expect their restoration to look like, feel like, function, and then of course, cost. So when you think about that, they're going to hold a mirror up. They're going to have whatever it's going to look like. They're going to be chewing on it, biting on it, licking, moving their tongue all around, feeling it out. And then function, of course, they're going to put it to use, but they have expectations. The challenge many times is they don't know how to explain it to you because they feel like they need to explain it more in the clinical terms. And unfortunately, many times clinicians have a challenge in communicating to a patient more at their level of dental terminology or dental knowledge. And that's where also many times our team members, the dental assistants, hygienists, your implant coordinators, they do a really great job of bringing that down to the level where the patient can really understand it using their words. I want my teeth anchored into my jaw. Okay, that's their way of saying I'd like to have an osseo-integrated implant into the mandibular arch. They have their wants, needs, expectations, etc. So we want to identify that, and we're going to go in great details in each one of these steps. But once you know what the patient expectation is, that's like your GPS setting. If you're going to go on a trip and you don't know where you're going, you set your destination. Your destination, in essence, is the patient expectations. And then now that you know where you're going with with their expectation, the next step is how do you get there? What are you going to fabricate so that you meet those expectations? So how do you know what you're going to make if you don't know what they want? So you may sit back and go, oh, in this scenario where edentulous in that posterior mandibular quadrant, we have super erupted opposing teeth, we have this, we have that. You can go through all your mental gymnastics of what you know about clinical assessment, what you need to, don't get me wrong, I'm not belittling that in any way, shape, or form. Understand about musculature, parafunction, all those wonderful things. But it's really what is the restoration, because each restoration has a different set of principles, if you will, or considerations that you need to take into consideration. So patient expectations is your destination. Restorative options are what are you going to make, or what are you going to fabricate to meet that expectation? Then the third step is now that we know what you're going to make, the third step is the biomechanics that how are you going to design or construct that restoration to meet everyone's expectations. The expectations of patients are going to be very high. The more money they spend, the higher their expectations are. The more time, the more procedures that are involved, the higher the expectation. It all goes hand in hand. So we need to understand now the biomechanics of designing that restoration. But by knowing what the patient expected, that identified what we're going to make, help to identify what we're going to fabricate. And now, because we know what we're going to fabricate, we can zero in on the biomechanics specific to that restoration. We start simplifying, you start pulling away a lot of the other concepts that really don't pertain to that. I'm going to explain that to you a little bit further in some of the charts that I have coming up. So now that we know how we're going to design it, then the fourth and final step is the team concept. And what I mean by that is how now are you as the restorative doctor, the quarterback in this process? Again, you may be both the restorative dentist as well as the implanting clinician in the case. That's even more responsibility you're taking on, more hats you're wearing, etc. But how are you going to share this information? You need to share it with the surgeon if it's not yourself. Share it with your own team so that, again, they don't have surprises and they have clarity. And very importantly, with the laboratory to make sure everyone's on the same page. You don't want to wait till after these implants are in to have the laboratory involved because it's too late after that. Proactive dentistry is what I'm sharing with you these 2 hours is about being proactive to what the existing conditions are. When you wait until you get people involved thinking about things after the implants are placed, you are being involved. Now if you like it, great. You're in reactive dentistry. And that can be very challenging. Some people like challenges, and there you go. You just keep going down that path, and you'll have plenty of challenges ahead of you. So, how do we share all this information also with the patient? What does the patient need to be made aware of in the process to really help them to stay motivated and to follow really the steps that are required of them? Because long-term success of this case, it doesn't matter how good you are as a clinician, how great the implant system was, how great the lab is. It's on the patient once they leave your practice and they're out on their own for the next 3, 5 years, and hopefully they are coming back every 6, 8 months or at least once a year for hygiene, home care rechecks, etc. But they're the ones that are going to be responsible for the longevity of it. And so they need to have buy-in and accountability. And when you bring them into this entire process pre-surgically, they have ownership of it. So that's very important to keep in mind that the easiest thing sometimes, believe it or not, for the patient to do is just write the check. The hardest thing for them to do is to have this prosthesis, this restoration, this treatment modality that you provided to last a lifetime is what their expectations are. Sometimes I'd say with implant dentistry, it's a lifetime in 2 days. They expect a lot out of it. So that's what we're going to be focused on is this 4-step process. So we're going to take a dive right now and we're going to talk specifically about the patient expectations. So I want to make sure each of these points are very clear for you because if you can't take this away tomorrow and start implementing it, I did you a disservice. So I really try to break my information down to make it very applicable. So we're going to be talking about aesthetics here because that's very important. Patients are evaluating you that way. So keep in mind, we've all heard this. So perception is reality. Okay. So this is what I like this. I'm going to show you something here. It's going to fade away and a drawing is going to come up. And you're going to have about 3 seconds, 4 seconds to determine what it is that you're looking at. Okay? So here we go. What do you see in this picture? Who sees an old woman? Does anybody? Okay, that's a good thumbs up. Does that mean it's an old woman? Good. Okay, you're seeing an old woman. All right. Some people are there going, an old woman? I don't see an old woman. I see a young woman. Who's seeing the young woman out there? Hopefully someone's seeing one or the other. Some of you may see both. So let's talk about this. Here's the old woman. This is her nose. She has a large nose. This is the bag under her eye. There's her eye. This is her chin. This is her, she has no lips. Okay. So she probably doesn't have her dentures in. So this is the old woman, her bangs. Now the young woman is looking away from you. This is her ear, her right ear. This is her cheek. This is her jawbone right here. Here's her nose, her eyelash. This is a necklace. So this is her neckline right here. So in other words, perception is reality. But trying to communicate that with the patient or extrapolate that from a patient of what they're really seeing, define the color green, things like that. It's subjective, but we need to try to be as least subjective as possible. That way, when we can do that and peel the layers away, we're going to be more accurate on hitting on those key points that the patient is expecting to have as a result of the treatment. So back to aesthetics, doctors, keep in mind that patients are going to evaluate you with this mirror by pink and white. Okay? That's what they're looking at. They may be looking, they may sure to look at shape, but not the way that you clinically would look at it, golden proportion and looking at all these things. But bottom line, they're looking at the pink and the white. So if you're evaluating a patient preoperatively and you see some issues that don't look normal, of the white, the teeth, but also the pink, a lot of tissue resorption possibly, just because you do a nice restoration and patient hasn't brought up to you the fact that I see that I have my crown and they didn't want to do some type of graft to cover the exposed root or what have you, cervical area. So bring that up, talk to them about that, point things out. Have you ever noticed this about that? How this is different length than this side over here? Bring those things out to them because they have what's called visual tolerance. They've been looking at themselves for however many years in the mirror. They don't see it anymore. They don't see that the tooth is distorted, the color, or that they've had recession. It's just natural for them that they don't still see it. So point that out to them because you need to help them to go from visual tolerance to visual acceptance. Because when we start changing things up with the provisionals and the finals, sometimes that's a challenge for a patient to go, even though it's better improvement, some people might go, wow, those teeth look too big or whatever. So things to think about in your communication with the patient. Okay, gingival harmony. We pretty much all know the concepts of gingival harmony. You get in the books and you can read all different things about what gingival harmony is. I want to break it down simple and just say gingival harmony is what either looks good, doesn't draw your attention to it, or you get focused on it and it's not so good. But really, it's also what you don't see. So what supports the pink? We all know this. It's the bone, right? So why is that important? Is because and again, we're talking about communication, patient expectations, but part of this communication is if a patient needs an implant, then something's gone wrong, either with their natural dentition, maybe some restorations have failed for whatever reason. Very often there's going to be bone loss in conjunction with that. And that would mean that you would have lack of interdental bone. And we know, I'm sure you all are familiar about biological width. And if you don't, you need to look that up, find out more about biological width. The tissue will only maintain itself anywhere from about 2.75 to I think it's 3.4 millimeters from the height of the interdental bone. And then it depends on is that interdental bone or is that papilla, is that in between pontics, a pontic and a tooth, two teeth, an implant, etc. Variations to it. But just because you don't know about it or are not familiar with it doesn't mean it doesn't exist. So check out biological width, get comfortable with that, and understand because in your treatment planning, even though it's a single tooth, it may be very necessary to do a bone graft in conjunction with the implant placement, or again, based on expectation, based on the physiological conditions, you may need to actually do a bone grafting ahead of time to make sure that you're going to be able to, that's going to take before you place the implant. And that could be delaying treatment 4, 5, 6 months. So again, no implants are placed yet. And if a patient doesn't want to follow your treatment because you know what it's going to take to meet their expectation, then sometimes you just say, I'm sorry, I'm not the right clinician for you. This is not the right practice for you. We wish you all the best, or refer them out. But You haven't placed the implant. You're not married to them. You're just dating right now. You're dating to make sure that you feel like this could be a long-term relationship. So, a dear friend of mine, and if you ever get a chance to hear Dr. Scott Gans, he's the godfather of computer, of CT imaging and a technology we've got. But he has a great saying. It's in his book, and it's been misquoted and quoted many thousands of times, I'm sure. But he says, the bone sets the tone, but the tissue is the issue. That's because the patient can't see the bone, but they see the tissue, so that tissue is the issue. So, thanks, Dr. Gans, for keeping us on track with that, my friend. So we're going to come back more talking about bone here. Heart, I'm sure Dr. Gans as well. So we're still talking about bottom left, by the way, the bottom left of my screen. I'm always going to try to have a little, where are we at? What topic we're on? We're still about patient expectations. So we want to understand what is our functional expectations, if you will, knowing that a denture, they say a lower denture has about 10% function of that of natural dentition. Implant supported overdenture, tissue supported. So this means you're still going to have the movement, maybe 50% of the function. It gets removable so that you lose part of that. It's your natural teeth are not removable, so there's some function missed. And then go into the high end, let's just say an all on X type of case. It's about 90% of function. Once again, typically we're not going all the way to second molar occlusion on these because of the potential for cantilevers, which we're going to talk a lot about that coming up on biomechanics. Stay tuned. But anyways, this is just something to keep in mind as well, that patients need to, they set their expectations to you. They want something that doesn't move rigid in their mouth, yet their budget is like a two implant locator overdenture, which is a fine restoration. It's a great, it can change people's lives. But if that's not what their expectation is, that's a failure to them. Even though you did everything right, the implanting surgeon, the lab, everyone did everything right, it's a failure to that patient. So again, it's what do they expect it to look like, feel, and the function. Now, when we talk about function, this really, as I alluded to in the last slide, is more about the denture or the overdenture. So do they want no movement of their prosthesis? Is minimal movement okay? That could be okay. If minimal movement's okay, then maybe you're okay with putting on a scale, you're weighing things out. Maybe an overdenture could be good with the locators. Improve stability of their current denture. I just want it not to come propelled out of my mouth when I speak, laugh, eat. And then also we'll talk about is the concerns of bone loss, because patients don't use the word resorption. If I typed in, I should have done it on here. You type in on your own computer resorption, it gets underlined in red. The computer doesn't even know resorption, yet we use those terms with our patients, expecting them to understand. So I think it's important, bone loss. And they need to understand too that weight loss is good, bone loss is not good, okay? So, but let's just keep moving along here. About function really has more to do with your removable patients, the patients that have existing dentures, or they have a lot of mobility in their terminal dentition, things like that. So, what really should a patient understand? Some of the basics about bone and the effects of the bone loss. So, we can show them models like this of showing here you are with how much bone you have with teeth and over time. But really, your challenge is to the degree that you can somehow find these online. I'm about to show you this. Show this to a patient, create some own little PowerPoints for yourself. They understand this. They get it, the fact that when you don't have any bone, you lose your face. You lose support of your lips. The size of your lips don't change, but they roll under and there's not much to put lipstick on. So this is a big motivator for patients, especially women, but men as well. So explain to them about the stages of bone loss. And here's your mental frame, but that's not going to change. But when you get these patients complaining about their dentures hurting and you look at their how much bone they have left, this is why their dentures hurt, why they don't stay in the mouth, obviously, but why they're hurt is it's sitting right on top of the nerves, and it can cause a lot of discomfort and pain for a patient. So you can say to a patient, when we extract your teeth today or in the next month at our appointment, this is what you'll have after initial healing. But again, we all know this is going to happen. This by nature, it's going to happen is over time. We don't know if this is 5 years, 10 years, 15 years. It varies patient to patient, but you are going to lose bone. And we don't know when and how fast it's going to happen. It's just, it happens. And so The more you can explain to patients to get them to understand what you're saying is helpful. And that's where I think these models, these are very inexpensive from Salvin Specialties. They're on a board and now they, instead of rubber bands, hold them on. They have little magnets. You can pull it off that little plastic board. The patient can touch it, hold it. But what's really nice is that you could even relate maybe some of their x-rays. If they've been a patient of long time, a patient of practice, a patient of record in your practice, that maybe you have x-rays of them 10 years ago and now you can show them where they are now. But just so that here's a nice little series that this is what it looks like in the mouth radiographically, and then here's something they can touch and feel about it. The more you can communicate to the patient to help them to understand what's in it for me. Radio station WIFM, what's in it for me? That's what they're tuned into. The challenge is you need to talk on that same wavelength. And they say that a dental patient has an average IQ of a dental IQ, not an IQ, a dental IQ of similar to a fifth grader. So that doesn't mean you get down and go, so how are you doing right now with your teethies? No, but it does mean that you don't use words just to try to impress them about your knowledge and that you have with all your schooling and your experience. Use their words too. If they're saying certain words of again anchored to my jaw, things like that, that they can relate to, they can relate to. But again, things like this, they're very relatable to that. So we all know about bone quality, right? So we're not in biomechanics yet. We're still in patient expectations. And this is what gets overlooked when you're looking at your radiographs, CT scans, or what have you, or you know, maybe just going by, this is some terminology that we've got from Dr. Carl Misch many years ago, as far as density, D1 bone, type 1 bone, type 2. It's not isolated to these exact spots, but it's a guideline and it's a common that usually the bone in the anterior mandible is denser than the bone in the posterior maxillary arch. So that's all fine and dandy. You're not going to explain this to a patient in the terms that we talk about it. But what a patient should know is that there are different qualities of bone in their mouth. And whether you use terminology like oak wood, and gosh, I wish I would have put that in here. I'm sorry, I forgot. Oak wood, spruce wood, balsa wood, styrofoam for D4 bone, something they can relate to, but they need to understand. But here's my whole point about this. What does that screen right there, what does that mean to a patient? And I asked this in my lectures for 20 plus years, and people go, nothing, not much. You know what it really what it equates to, what it means to a patient? When do I get my teeth and how much is it going to cost? Now think about that. When do I get my teeth? You want to do medial lobe, they hear about medial loads on the internet, what have you. Yeah, it's pretty easy to do medial loads at lower anterior, good D1, D2 bone, maybe even in D3 bone, D4 bone, maybe certain conditions. But the point is, it's when do I get my teeth is also the integration period. Mandibular arch, you're probably going to wait less time than you would in the maxillary arch to let the implants integrate better. They also is how much it's going to cost if you're replacing, maybe you're replacing two pontics, the patient's missing two teeth, and you're going to put in, instead of putting in maybe two implants and one pontic, I'm saying that wrong, I apologize. But let's say it's a 3-unit bridge, two implants and one pontic, but the bone quality is very poor and you really don't want to have a pontic. You need to have one implant for each tooth. So now you're talking about three implants. That cost just went up 33%, let's say. That's due many times to the bone quality. Again, pre-surgically, you're not surprising them with this. It may be a surprise to them, but it's not that you're married to them now and you're surprising them with this. You're talking to them about this to make sure that they're a good candidate for themselves for the treatment they're looking for, and are they the right patient for you and your practice? So keep that in mind. That's how bone quality means to a patient. And so more about bone loss, what we know is that a survey was done by the Institute of Dental Implant Awareness, which, by the way, missingteeth.org, it's a great site. It's generic for patients to even look at, talks to them more in their terminology. But they did a survey and they found that 65% of the patients they surveyed said no thank you to the implant treatment therapy they were offered. But once they understood the consequences of bone loss, what that really means to them, that They said yes. 65% of them said yes once they understood it. So don't underestimate the value of helping a patient to understand about bone loss and how that's going to affect the case from an aesthetic perspective, as a functional perspective, time for letting grafting integrate, cost because you're having to graft, etc. Okay, so we made it through patient expectations. So hopefully you've got a snapshot of that. Once again, that's your destination. That's where we're going. Now it's how are we going to get there? So that's our restorative options. And let's take a look at this. So we have a lot of different options. That's the good news about this, based upon the condition that the patient is in or about to be in. So how do we figure out what's best for that patient? So I want to share some points with you because it's also about surprises, not trying to minimize or avoid surprises. And one thing is that affects the case is biomechanically, even though we're about restorative options. Again, remember I said early on, they all tied in, all four of these concepts are integrated to each other, or they're related to each other, tied to each other. It's hard to separate them apart. We pull them apart to evaluate it, got it, and put it back together, and pull it apart and evaluate it, and put it back together. So let's pull this apart. Let's talk about the implant itself. So we have obviously different types of implants based upon the conditions, narrower bone, less vertical height. So we do know that about the most common diameter implant, and not picking any implant system in particular, but the most common diameter is around 4 millimeter diameters, okay? Whether it's 375 or 4.2, 4 millimeters is a good common diameter. Length of an implant, some I think there's even narrow, shorter implants than 7 out there, and they go up past 15. I'm not talking about zygomas or pterygoid implants, but just your root form implants. Most common length is around 12 millimeters. And so, having said that, if you're looking at a case and you can look at it and say, hey, a 4 millimeter by 12 millimeter implant in this situation, okay, maybe it's a single tooth situation. Wow, you got some good length there. You got some good diameter there. You're not coming in with a 7 millimeter, say a 3.2 by 7 millimeter on a first molar, right? Again, just keep in mind about teeth replace roots. I'm sorry, implants replace roots, not necessarily teeth. They are root form implants. They're not tooth form implants. And that's something I've heard. I don't remember where I heard it from, but it's a long time ago, and it's still true to this day. All right, Bean, we got you. We're going to go on to the other. Thank you, Bean. So when you get less than that, you start getting that, your inner being starts saying to you, or you get a little voice going, are you sure you want to do that? Listen to what's going on. Doesn't mean you don't do it, but what it does mean is you're going to start diving more into what I'm going to share with you right now. And that is, this is a checklist, if you will, for lack of a better term, of biomechanical considerations that can affect an implant case. And you can find more of them out there, I'm sure. But this is something that came up with this many years ago. Actually, Dr. Charlie English helped me with a section of the book that I wrote, oh my gosh, almost 30 years ago on biomechanics. And I just said, think out loud. What are the things that you think about when you're treatment planning a case? And those of you who don't know, you're going to see this coming up. Dr. Charles English was a renowned prosthodontist. He's the one that came up with the AP spread, the critical anterior posterior spread. We're going to catch that coming up in biomechanics. But this is just a list that we came up with. All right. So when we think about that's something we want to keep in mind. Have that like your little pilot checklist for taking off. You go through your little checklist. Landing, you go through your checklist. So what we want to look at for now, I'm going to talk about crown and bridge. Most of you are used to me probably only talking about overdentures and all on X, but I'm going to also talk about crown and bridge implant tooth replacement therapy. And when we look at a case, we want to look at what are some indications for doing this, whether it's cement retained or screw retained, what are the contraindications. And of course, you also have advantages and disadvantages. It's all a balancing act that you try to put the scales in your favor and your patient's favor. So cement retain, that used to be the way we did everything. Say, first off, everything was screw retained for a crown and bridge. Then it went to cement retained. for a lot of these reasons right here that I'm just going to click on them. The reasons that we had these for a cement retained, a big one, I remember doing these many years ago, a lot of crown and bridge cases. It's just like crown and bridge. We could do it's like post and core dentistry doing cement retained. And then it really fell out of favor for the reasons of excess cement causing things, screws coming loose, restorations coming loose. And I'm just sharing with you some thoughts and information for you to make an informed decision. A disadvantage about a cement retained restoration, say for a single tooth, is that there's some minimum inner arch space required. And what we've seen in articles, and I think I got some quotes of some coming up here in some couple of slides, is somewhere on this 4 to 5 millimeter. I have some images I'm going to show you coming up. And disadvantages, again, removal of excess cement, getting it when it's subgingival, it's hard to get rid of that. There's techniques to help, do pre-cementation of the crowns before you seed them so you don't have a lot of excess cement, but we're not covering those techniques tonight. But I have information about that. But here's what I wanted to say is that an indication for cement retained is you need to have some height here for the crown to bond to the abutment. So you're going to have a collar of the abutment. Abutment's going to have a collar. And in articles I've looked at, I want to say studies, but I don't recall exactly if they were the studies. But the number that I've worked with for many years is that if we can have at least 4 to 5 millimeters of an abutment, that a cement retained crown onto an implant abutment, whether it's a custom abutment or stock abutment, to cement on that surface area, that usually that's step one in helping to have a good long-term restoration. When you start seeing more of the restorations debonding, if you will, so that's where the scale would go into more favor. When you get short clinical crowns, the scale goes more in favor for a screw retained restoration, because the shorter you get, the better retention you have with a screw retain. And bottom line, about the minimum you can do from the platform of an implant to the occlusal, to the head of the screw, is about 3.5 millimeters. So if you have a edentulous space and an opposing tooth is super erupted into that space, and you're just looking in the mouth, and if you don't have at least 3 to 4 millimeters, you need to pause right now, because you may not have room for that restoration. Now, you may go ahead and put an implant in and get that in, but when it comes time for the crown, and now you have to do a screw retain crown, but there's not enough room to put flowable composite over it to make it look pretty. Now the patient's looking like they have a bad amalgam filling, and they just paid $3,000, $4,000, $5,000, whatever they did. They're not going to be happy. Granted, it's clinically sound, but they didn't meet the patient's expectations. That's a failure. So we want to avoid those things, okay? So another, what this again, information about what causes restorations, cement retained restorations, or really even screw retained restorations, but crown and bridge restorations. Spit it out, Jeff. Crown and bridge restorations to fail. Parafunction, it's a big one. I think we all know that. Long span. You have the longer the span, more pontics. Also, there's more flexure. Depends on what type of material you're using. That can cause a problem. Cantilevers, you're going to hear this more today when we get into biomechanics, but cantilevers are nothing but magnifiers of force. And we see a lot of fracturing happen in cases that have cantilevers, and we'll talk more about that. Or you splinted them to natural dentition. And even though that crown was cemented to the natural tooth that wasn't mobile, but there's no periodontal ligament on an implant, and that's a bit of a problem. You have two unlike conditions here, and what you have now is that natural tooth you splinted to, unless it's a multi-rooted tooth, for a very high probability that you just create a cantilever off that single tooth implant, and cantilevering off a single implant is considered to be contraindicated in implant dentistry. People are not probably talking about that, but when we got pounded years ago about failures and what we learned early on about this and how to prevent them. These are the things that we're talking about that I think are important to make sure that we keep it on the forefront of your thoughts when you're designing cases. Offset access loads, we're going to talk about that. And then horizontal loads from occlusal design. Here's another tip. When we have, whether it's an impression coping or X or an abutment or something you're seating that's subgingival, you can't visually see to verify if it's seated completely on whether it's a platform or the implant, or maybe something onto a multi-unit abutment. But if you take a look here and this incorrect position, what we're talking about position isn't the abutment, because this is the same. Nothing, I did not change the abutment in this position from these x-rays. All I did was have the assistant change the position of the x-ray tube to make it perpendicular to the interface, if you will. I was told, think bite wing, okay? That's what you want to do, is you want to just be straight look right directly at that occlusal plane, if you will, but you're just dropping it down to the implant to abutment interface or the impression post interface. But here's your key, folks. How do you know you got this at the right angle? The one here on the right, whenever you have a radiograph and you see the threads, that tells you that at that area, whether you're doing a pano and it comes around and oh, now the threads are clear, that way you can more or less count on that. Whereas the left, you don't know for sure if that's a go or no go. Those are things that can cause surprises. Again, we're trying to eliminate that. Here's a restoration being seated. Again, same case. I didn't change anything, but it looks seated. Oh, but now we change the position and look at the threads. Once again, the threads were blurry here on the left, but when they're clear, this is not trick photography. This is actually what happens. Now I could see that it wasn't seated. Maybe the contact was heavy. I did this a long time ago. I don't remember what the scenario was with it. But just a good tip is just take an x-ray. They're quick and easy to do. Patients expect these to last a long time. Don't be in such a rush. Let's just do things right for the patient and for yourself. Especially you young dentists out there, you're going to be around a long time. Patients won't forget where these were done. So here's another thing I don't hear people talk about: splinting multiple implant restorations together in the arch. A lot of people think I want them individual, easier to floss through. Granted, that is, and true, hygiene is important, a very important consideration. Remember the scales I showed you earlier about balancing? So here's where you need to make the clinical decision, the clinical call. But here's reasons. Again, I tell you what, I've learned so much from Dr. Carl Misch and his writings and the people that have contributed to his book, and clinicians all around the world that I've been fortunate to hear and be tutored by, many of them, I hope, that have really helped me. Higher success rate when you splint. Look at the difference. 15-year data. Less screw loosening. Whoa, that's a big one. 3-year data. 48% versus 8%. Big difference there. But also just less stress to the system, because and I'm going to say this a couple of times here, your goal, our goal, if we're working together on the same case, or anyone on that team, okay, the goal is to design and create a situation biomechanically, physiologically, in the patient's mouth that during function that is going to allow the forces generated during mastication to be distributed as quickly as possible and a greater area as possible to the degree that you're able to do. That's when you see the long-term success on cases. It's when you don't have that, you get isolation of forces, magnified forces, you get screw loosening, fracturing, you get bone loss, you get implants coming loose, and it's just a kind of a downhill fall from grace, so to speak, from that. So there are good reasons to splint, and there's also good reasons to keep them independent. But really, independent really is probably the biggest one is on hygiene. So really weigh that out on the value of that. So here's something else that I find happens, that whether you're doing single unit, multiple unit, or you're doing your all on X cases, that when we're exposed, or you're exposed to, say, softer bone, you place the implant and wow, I got pretty good stability. Maybe I got 25, maybe I got 30 newtons, but the torque manufacturer says that the torque value of that abutment screw into the implant is supposed to be 35 newtons of torque, and my insertion torque was maybe 30, and I'm comfortable with that maybe for immediately loading it. But my concern is that I want to tighten that abutment on. If you can either maybe just do finger pressure, then you got some possibilities of didn't get seated all the way. So here's the tip. If you use, they actually have a hemostat that has slots cut out for it. They're called an abutment clamp that will have some flats to it that will clamp on, but a hemostat works well. Usually a cotton tweezers, a cotton pickups is not strong enough, but a hemostat, clamp it around the abutment, and then you go ahead and apply the torque because what you're doing is when that torque from the torque wrench is being applied to this to the abutment screw, the screw then is transferring that torque to the internal threads of the implant. Then the implant would in turn put that torque, that rotational twisting force, to the interface of the bone to implant. It's not integrated, and you could just loosen up, you could strip that out a little bit. So by doing counter torque, where you're holding the abutment and counter torquing, so if you're torquing, you're almost going opposite direction, and for sure holding that steady with the abutment clamp or your hemostat, and then torque. That way, you're only putting that preload onto the abutment screw to the internal threads of the implant, not transferring those to the wall of the implant. I'm sorry, the threads of the implant, the outer wall, outer threads of the implant to the bone interface, which is very fragile, quite frankly, at this point. And then the other thing, if you're using these breakaway torque wrenches, which I really would say if you got them, get rid of them, get the bar, the spring type torque wrench. These can go out of torque if they're not taken care of properly, autoclaved properly. You have to recalibrate them on occasions, and it could be applying a lot more torque than you think. But the point is, once that head releases, don't keep torquing. You're going to strip and bend, ruin these components. When implant manufacturers tell you their torque values, use the ones by the company you're working with. And the reason for that is that the torque values that they set was determined upon coming up to within about 75% of the yield strength or deformation of that component. And so you want to get it as tight as you can possibly get it without deforming that. And that's how they configured their torque values. So if you're using a different company or a non-OME part, an aftermarket, less expensive part, and you try to put that same torque on it, you could be deforming that and causing some real problems and some real issues. So there's a reason for everything, quite honestly. So I'm going to get in now to a little bit more about, again, minimizing surprises. And what I'm talking about is implant failures are not good, restoration failures are not good, the combination thereof is not good. So, what do we know? What has history taught us? What do we know that we've been doing this kind of dentistry for many decades now? And what studies have shown here, and how much better do we get than our friend Dr. Tarnow and his colleagues here, and these people that have spent the time? You could go, oh, that's old data. You know what? It's still valid today. But let's look at this. Just play it as safe as you can, and I think have things be as predictable as they can. I've used these guidelines for years, and they've served me well, my doctors well. So that is this: to try to maintain 1.5 millimeters of space or bone between the implant and adjacent tooth. If you have two implants, pardon me, you want to see 3 millimeters of space between the bone and the implants. That's part one. So let's take this concept here, and let's say we're going to run with that, and we're treatment planning a case. You have a patient, you have taken, whether you did some just IOS scans, you took impressions, whatever you did, you have your edentulous space there, or proposed edentulous space because you're going to edentulate them, extract some teeth. But let's say this. So this is an exercise that I did where I went ahead and, oops, sorry. I went ahead and just looked at one particular diameter of small regulars with an implant company that I was working with at the time. And I said, okay, so if I'm going to do two implants, okay, we're going to do two implants here. And if we use 4 millimeter diameter implants, that to meet this goal of 1.5 between the implant body and an adjacent tooth, the root, if you will, and then have 3 millimeters in between, you really need to have a space of about 14 millimeters. These are guidelines, okay? Don't get hung up. My point is, that there are some numbers that you should be looking at. And if you see this instead of 14, you see this at 10, and you're thinking two implants and you're thinking regular diameter, you're going to have an issue because you're not going to have enough bone between the implants. Or when we say space, we're talking about bone volume. And what does bone do? Bone allows vascularity for the osseointegration to occur, for the bone cells to regenerate. Without that vascularity, you're going to have dehiscence. And that's where we see bone loss, failure loss, one of the reasons for that. Okay. So there's a little bit of a guideline here for you. Now, let's take that another step. There's a concept that we used to do, talk about the center to center of spacing of implants. You go from the center to center, lay it out on the model, and what we following the same guideline of 1.5 and 3 millimeters. Again, I'm just going to stick with our 4 millimeter diameter. That if you did the spacing of an implant, center to center of your implants, say you do a surgical guide, you've set up a couple of denture teeth, or the lab set up two denture teeth, did a suck down, something simple as a suck down surgical guide, and you look at the center of the implant, the center of the implant. If you did 4 millimeter implants, that's going to give you the math to where you'll have your 1.5, your 3. There's 1.5, there's 3, there's 4 again. There's that all adds up to all those numbers add up to that 14. So here's the implant center, it's 2 millimeters. There's 3, that's 5, and there's 2 more millimeters because it's only half of that implant. There's your 7. Okay. Now we're going to do a little bit of focus though. I still need to come back to my fave, the all on X, and talk about some decisions that we need to think about here. And again, they're not limited to what I'm going to share here, but these are like mandatory considerations, decisions that you need to be looking at. Parafunctional habits, my gosh, can't say this enough with any type of implant restoration because there's no what? No periodontal ligament that is your fudge factor, your forgiveness. These are all ankylosed teeth, if you will, the implants into bone because there's no periodontal ligament. So parafunction is the effects of parafunction are magnified on implant supported restorations. Bruxism, you really got to watch out for that. Night guards are going to be mandatory for those patients. You got to get patients to sign off if they want to go forward with the treatment. And if they wear a night guard, you'll know if they're wearing a night guard or not. You can just tell by looking at them, right? The physiological and biomechanical considerations. Look at how many implants, were the length of those implants, how wide were the implants, was the quality of the bone, was there an anterior spread, what's the musculature like? All these things, you just got to be able to pop that to yourself. Say, looks good. 2 implants or one implant or whatever, but what's the bone like? What's the musculature like? Is there parafunction? What's the opposing dentition? All those things they all play. Some may have a more important role than another. Cantilevers, you're going to hear cantilevers a couple more times yet because I'm not even in biomechanics yet. We're heading there, we're getting there. But cantilevers, they're magnifiers of force. So when you have them, you have to be really aware of all the other factors that we're talking about here because that could add more complexity or more risk to the case. And then again, the patient's expectations for this all on X case, are you going to be able to meet their expectation? What I mean by that, a lot of it has to do with inner arch space and what type of prosthesis you're going to use, the cost of those restorations. But a big one really is their home care. I mentioned this earlier that once they leave after you've delivered the final prosthesis, that it's up to them, whether it's a single tooth, multiple crown and bridge, overdentures, all on X. The longevity of that really is going to be based upon their home care and them coming into you for reevaluation, whether it's semi-annually or annually. That's your call on that. So let's go a little bit more into this. So inner arch space. Now we're talking about all on X, okay? And so this is where we need to have some clarity here. When we talk about inner arch space, you need to know for sure when you're talking to your laboratory. I'm assuming for right now, I'm talking to my restorative doctors out there. If you're talking to your implanting surgeon or you're talking to your laboratory, make sure that, especially that all three of you need to be on the same page here. So as a quarterback, again, make sure you're all talking about the same play here. And that is that where are you measuring this restorative space? So one option is to measure it from the implant platform up to the occlusal plane could be called your restorative to the occlusal plane is your restorative space. Some people, though, will say it's from the top of the multi-unit abutment to the occlusal plane. Now, you may think that's not much difference, but if you had a, say, deep tissue and you used maybe a 4 millimeter cuff multi-unit abutment and you're measuring 4 millimeters up from there, do you see the difference between using a 1 millimeter cuff MUA? There's a lot of difference. So you need to make sure that you know what you're measuring, that you're measuring the same thing the lab is, and the lab and the surgeon, everyone's on that same page. This will help to give you clarity. It'll help to minimize surprises. So the clarification of this is really critical, and really it's mandatory because otherwise you're gonna have surprises. It also is going to affect the restorative material because if you're going to not have a lot of room, you may have to go to, instead of doing, say, a zirconia final, instead of doing a hybrid denture teeth acrylic and a bar, which typically is significantly less expensive than, say, a zirconia, you're going to have to go zirconia because you can go with a less restorative space and still have long-term results with that. Maybe the difference as much as 3 to 4 millimeters. You're gonna go back to the patient now after the implants have been placed and you've already collected check, let's say, and you're gonna say, oh, now my lab fee is another $1,500 or $2,500 more because of your space, blah, blah, blah. You can't, so folks, don't even go down that rabbit hole, okay? So these things I'm sharing with you are for a reason. This isn't marketing fluff. This is real world things. Also, look at what is the opposing dentition, natural dentition. Is it going to be lost in short term? Is it going to be there? You don't have a crystal ball. I get it. But is it something that has 5 year longevity or is it something 10 years? Is there crown and bridge work? Is it fixed implant restorations? If it's fixed implant restorations versus an overdenture, you're going to have different biomechanical forces, et cetera, et cetera. Okay. So just taking a look at these options, I'm going to run through these quickly for you because it is about restorative options. So 4 year all on X. Let's take a look at this. These are also this webinar will be available on our website. You can watch it again. And sometimes I may go a little faster on some slides, but no, you can always come back. Repetition creates certainty and view these again. I think the main thing I want to say about the hybrids that we've been doing for 20 years or whatever, that the drawbacks is yes, teeth could still fracture off. Yeah, great. Now we are printing these monolithic dentures. That does help, but not everyone. I think 20% or so of dentures are being printed or milled, mostly printed. Great material, but the volume still isn't there. But that's something to think about. That may be a very good way to go when you're doing this type of a restoration is to go with a printed denture like that. But it does require typically the most amount of inner arch space. The zirconia, on the other hand, is going to be allow you for the least amount of inner arch space. And some labs may even go a bit less. They may say 11 millimeters, 10 millimeters of that restorative space. But can you see why I was referring to you need to know where you're measuring? Because we start talking and comparing in 2 to 3, 4 millimeter increments here, and it makes a difference. The big thing about this is that the zirconia is going to potentially wear opposing dentition almost regardless of what it is. Night guards, highly recommend it. I think a key benefit is hygiene. Really, a big one is the hygiene for a patient. If they're not usually good dental patients, no offense to the. So this really could be and that scale you're weighing it out is that this could be the best restoration for them. Yes, it costs more, very likely, but then that's where you're pre-surgical, right? You have that conversation with the patient, the what's in it for me, the with them, radio station WIFM, Mrs. Jones. The reason that this restoration is best for you is because of your home care. You have arthritic, you have poor vision, or you just haven't demonstrated even on your provisional that you can take care of this. And I can't be there every day for you. So this is going to cost you more money. You guys put your own spin to it, but I think you get the idea of what I'm talking about. But you have to have those conversations with the patient. And it's okay if they say, no, thank you, I'm going elsewhere. Because I tell you what, you didn't want that patient in your practice. You do not need the money that bad. I promise you that. Because that money is not real money. It's going to come back and very likely could be failures. And any one remake takes 5 new cases of the same value to make up for the loss of one remake. So keep that in the back of your mind. Drawbacks with this, I think a big one might be the clacking noise, but that doesn't happen with everyone or bother everyone. Nanoceramic, we really saw a lot of this being done maybe 3, 4 years ago when it was really making a big push. Not seeing it that much, at least through our laboratory network. Nanoceramic, this is something where this material it's a material brand name called Trilor where they make a bar. This is the nanoceramic milled from a puck, and then the laboratory would cement that on, and then they would hand paint this pink. Many times it's a lab heat process material similar to something like Garadia. There's other brand names as well. What I liked about it was the fact that it is quite aesthetic, but it still can stain. But I like the fact it's repairable, that if they fractured a tooth, chipped a tooth or something, it could be repaired. I actually relined a couple of them, a little technique that you need to do that. And then drawbacks, again, you may have to, it's glaze, it's a light cure glaze. That'll have to be redone maybe every year, things like that. So things to talk to your laboratory about. Labs that are doing full arch, they know all these things. You don't have to know everything, but just know to ask the questions to your lab. Then that high one on the scale, we call it a thimble bar, where it's a titanium understructure. The lab's going to prep all the teeth, opaque it. We'll fabricate 12 individual zirconia crowns. It looks very individualized. So now we are looking at the biomechanics. You can't pull them apart, but now let's pull out biomechanics from this 4-step and let's get a little zero in on some key things that help to minimize surprises and provide clarity. So now that we know, again, what we're going to make, how we're going to design that to meet all the expectations, and that really is planning. And again, I keep saying this, I think I'm saying it quite a few times. I feel like I am a balance. And so that's the best you can do. And I think you working at team concept, you got a lot of people helping you to balance it. So this is that statement I made earlier that the treatment planning process, both surgically and restoratively, must focus on the distribution of stress generated during functional movements. What's missing from that was the other quote that is, to the degree that you can distribute these loads that are generated during mastication as quickly as possible and greater area as possible, that's where we're going to see the long-term success on these cases. All right, let's talk about forces of occlusion. And just because you may not know these things doesn't mean that they're not going to affect your case. And so to my lab friends that we have watching this too, that you need to help educate your doctors on this, because whether you're learning this for the first time or you already know this and you're not sharing it with your clinician, you need to be sharing it with them because we're all in this together. You're all in this, you're all cooks and chefs of making this for the patient. So compressive forces are forces that tend to push objects toward each other. Okay. Tensile forces, they tend to pull objects apart. And objects could be implant to bone. So a cantilever could be based on where the cantilever is. It could be putting compression on this bone. If the cantilever is going off posteriorly, it could be putting compression here, but it's pulling that implant threads, the implant wall against the bone here on the mesial, let's say, opposite the cantilever. And that's a tensile force or a pulling force. And that's where we'll see some saucerization possibly. And then really the worst forces are these shearing forces that they say disrupts the interface of objects. So, but look at these numbers down here. Bone is strongest under compression, is 30% weaker under tension, and it's 65% weaker in shearing forces. So that's where we have to watch our occlusion. That's why night guards are important. That's very important for you all to think about this. It does have an impact, okay? So these numbers don't lie. Now this is an old, but the body hasn't changed. I don't think how we develop in life from an infant, trying to not get politically incorrect, but let's just say in 50 years, we're not much different, really, how we've evolved. How about that? Let's move to the next slide, Jeff. Okay, so let's focus on some real specific topics to crown and bridge. And this is that whole list that I showed you earlier from A to Q. So you're going to need to just kind of extrapolate when you're talking about a case, like a type of case. So our restorative option was going to be crown and bridge. If I'm doing a crown and bridge, I need to kind of check all these out for biomechanics. So let's dive into that. What does that mean? All right, so here we go. Oh, got to add to that for your overdentures and your all on X, we are going to look at the letters MN and O, which were cantilevers, AP, and spread. So first, let's talk about the angle of implant. This is where my own personal belief is that thank goodness we have angled correcting abutments, 17-degree, 30-degree MUAs, custom abutments. Labs can get pretty darn creative. Milling centers can get pretty creative. So we're not limited to what is pre-manufactured. But here's something that I think is important to just be aware of, that when occlusal loads that are directed down the long axis, so down the long axis, the loads down the long axis of the implant, that it creates a compressive force, which that's a good force. Bone kind of likes that to a degree. And it's measured in stress is measured in micro strains, and there's still a level of too many micro strains, bone starts to hiss or go away because it doesn't like it. But compression forces are more favorable. Off-axis loads can create more of those tension or shearing forces. And if you look at the image here, yes, we used an angle. So now we have this abutment going off to the side here with the screw axis hole coming out here. But even if we put an angle correcting on that, we still have a propensity of loading up at the platform of that implant. And so this is what I found interesting was for every 15 degrees, the load was off that long axis. About 25% of the load goes right into this connection area. So we wonder why sometimes screws come loose or restorations come loose. We didn't use maybe the proper torque wrench, or we didn't use a torque wrench, or it was out of calibration, or we were severely angled, or we had a small diameter. We didn't have a lot of surface area, short implant, narrow, all these factors. So my point is, when you start getting any one of these considerations, then all the others may get magnified. And what I mean by that is that, so poor quality bone on angled implant, that could even magnify more of the stress to that bone to implant interface. So again, you got to look at all these other issues. So keeping along that thought process, so if we have this angled implant, I have to be thinking a little bit more about what is that bone quality? Is it a type 4 bone, that D4 bone? Okay, what was the diameter of the implant? Oh my gosh, it was a small diameter. It was in D4 bone. Oh, and yeah, there's parafunction. What if we have, let's keep looking at this, and let's say we have the crown to implant ratio is whacked. We'll talk about that next slide or so. The diameter restoration, but look at here, a cantilever. Wait, a cantilever on a single tooth? Yes, sir. Anything that actually is beyond the wall of the implant, so any part of the restoration that is beyond the wall of the implant could be defined as a cantilever. The difference is there to some point, this isn't science, this is just Jeff talking. There's some point where there's an acceptable cantilever, meaning your normal contoured crowns. But when you see maybe an implant like this that maybe got positioned a little too far to the mesial, and the lab had to extend that crown post distally, and now you actually created a bit of a cantilever here on a single tooth implant. By the way, cantilevers on a single tooth implant are considered to be contraindicated because they're magnifiers of force. Also look at the opposing dentition. That's a lot of load. There's no forgiveness here. There's no opposing teeth, natural dentition opposing with periodontal ligaments to give a little bit. All right. So again, if you're going to be angled, look at everything else, because if it's angled and you have a cantilever, oh my gosh, at some point, when are you going to say time out here? We're pre-surgical. No implants are placed. That's the beauty of this. This is where we don't have as many surprises following this 4-step technique. So implant to crown to implant ratio. Everybody knows crown to root ratio. I want to clarify something here because I'm not hearing many people talking about this anymore. And I do go on a lot of webinars, go to a lot of classes, but the ratio, so let's talk about the ratio of the crown height, okay? So the crown ratio, it's measured from the surrounding bone around the implant, okay? So the crown height, okay, is where and it's not just, okay, here's the bone, and that's the ratio. It's the top of the implant. But let me ask you something. What happens if you have bone loss for whatever reason, and now you don't have bone until maybe the first thread? That just because this is the implant, that doesn't mean that's implant ratio. If you don't have bone supporting that implant, anything that's above the bone to implant interface, anything above that is should be classified or considered to be the crown ratio. So this is where that, and they say that ideally the crown to implant ratio, and when I say they, here's some of the studies that have been out there that talk about that the crown to ratio should be a 1 to 1, but even better is to have only, so to have more implant ratio than crown ratio is ideal. So if you can go longer, once you get to about 15 millimeters, there's also been articles and studies that show that after 15 millimeters, unless there's bone loss, you're not really gaining a lot more biomechanical support after about 7 to 8 millimeters during function. So going longer than 15 may not be a benefit. But again, based on conditions and different things like that. I'm just trying to bring things to your attention to look at, do we have bone here that is actually supporting that implant rigid to make that part of my implant ratio, or do we have bone loss and I have an increased crown ratio? Okay, I hope that makes sense to y'all. Again, one of my geeky drawings I get into. So knowing that is a kind of a guideline, all right, then you have to say to yourself, once again, what if I'm not a 1 to 1? What if I have even less implant ratio? Then you, once again, you go back to that list and say, what was my bone quality like? What was the diameter of implant? I had good bone, D2 bone. I had a 4.5 diameter. I have a straight abutment, no parafunction, no cantilevers, opposing dentition's a denture. Those just makes you feel that much better, right? But unless you're going through that checklist and evaluating, you don't know. And then you get surprised. So let's talk about something else. I don't see as much of this being done as it used to, but I know it's still being done, and that's splinting the natural teeth. And there was clinicians that I've heard out there lecturing to say it's okay to splint to a natural tooth. Okay, this is something I've been involved in. This drawing actually was something that I worked on with a medical illustrator 30 years ago when we were talking about this, when I did this book I did many years ago. And it's still the same thought process. And what that is this, that teeth don't support implants support teeth. Why is that? It's because they have a periodontal ligament. Now, a multi-rooted tooth, if you're splinting this implant restoration to a molar, you got a maybe a little different story going. You got multiple roots. Maybe you have an ankylosed tooth. Okay, I get it. But in general, it's not a good idea to splint to a natural tooth. If you're going to splint an implant restoration to a natural tooth, I say ask yourself why. Why are you doing that? Are you doing that because you want to support that tooth? You want to make that help that root to last longer, that crown to be there longer? You're going to splint to that? Okay, you did that. You just created a full cantilever on a single implant in this scenario. Was that really a smart thing to do? I don't know. You have to make those decisions. But what do you think in this scenario would be the best situation for long-term success? And let's say you are going to splint to that tooth and you want that tooth to be there a lifetime, that natural tooth. The best solution really would be, and all you are already saying this out loud, I can hear you all the way here south of Minneapolis, in the country, you're saying add another implant. Absolutely. Now, this is a different scenario. This is not teeth supporting implants. This is implants supporting a tooth, okay? World of difference. But yes, there's additional cost here. Oh, guess what? You don't need to eat that cost because you planned this ahead of time. You thought about this already ahead of time, but there's no surprise. Cantilever. Oh, cantilevers. Avoid them when you can. Remember, they're a magnifier of force. If you have a bruxism, patient with bruxism, you really should just, cantilever should be contraindicated. Always a night guard. Really need to be a night guard with cantilevers with the patients. Minimize the length of the cantilever, of course, if possible. Use additional implants. If you're doing only a 4 implant mandibular restoration, or maxillary, go 5, go 6. The cost for you for one more implant, the time is almost nothing to place another implant, just a matter of a few minutes. Yes, you have a cost of an implant, but in the big picture, the patient deserves to have the best treatment modality for them. All on 4, none on 3. We heard all those sayings, but design this case to hopefully last a lifetime in 2 days, and I think you will have more clarity and less surprises. Cantilever anteriorly versus the posterior, if that's possible. Think about that maybe in a bar overdenture kind of a situation. Maybe you could cantilever out anteriorly and not be rocking posterior where the magnet, forces are 4 times greater over the first molar area than they are in the anterior. So that could be something, is to get that cantilever away from the strongest mascatory forces in the arch. Then getting close to the end of our biomechanics here, then we're going to look at the anterior posterior spread, AP spread. And this again, Dr. Charles English has to get credit for this. He wrote this in 1986, I believe it was. It's called the critical dimension of anterior posterior critical dimension. And so when he explained it to me, I'm sharing this as how he explained it to me. And he said that if you have your 4 implants here, you draw a line through the center of the 2 most anterior implants. Now, granted, we're getting ideal lines here, but I'm going to talk to you about that a little bit here. And then you draw a line through the center of the 2 most posterior. You know what? It's a guideline. Whatever works for you. This isn't rocket science. It's a guideline. It's like saying it's 55 miles an hour on this curve. Sure, you could take it at 65 and be fine. Okay. But wait a minute. What if it's wintertime, you're in Minnesota and it's ice and the AP spreads, says you can go 55 miles an hour. You don't do it because you have other conditions. In other words, you're going to go to maximize your AP spread. You better look at the other conditions. What's the bone quality like? Is there parafunction? I know you're getting sick of hearing that, but that's what you need to have. Someone wake you up in the middle of the night and be able to say those things. And that's how you want to evaluate your cases. So once you draw that line and you measure that space between the lines and you multiply that, I call it the magic number, 1.5. What he came up with, he evaluated over 1,200 cases to come up with this number. He didn't just pull it out of the air. He looked at failures of cases, of bar cases, and he came up with this number of 1.5, that there was a correlation between failures and how far this cantilever was put out there. So in this particular patient, following this concept of a 1.5 times your space, that equals 12. So 12 millimeters is the furthest you should cantilever this case. Now, would you automatically go and do that? No. But let's talk a little bit more. I already said why, because what's the opposing arch? What's the musculature? How long were those implants? How wide? What's the bone quality? Here's another thing. Oh, on the lab, I'm going to design a bar. I'm doing a bar overdenture, and I'm going to design a bar with 12 millimeters of the bar coming out. Then the denture is going to snap on over that bar, and I'm going to have 4 locators on that. Boy, this is going to be rigid. This is going to be just like an implant-born solid case. I'm 12 millimeters out, but I have a denture tooth over here and then a little flange off of that. I may actually be extending out here maybe 15 millimeters because maybe the occlusion isn't there. But if I bite down on a raw carrot and I have the propensity of a bolus of hard carrot to get back and be masticated and create some force back here, I just now have a magnifier, a cantilever way beyond any guidelines. So AP spread's a guideline. You can't just say, I did that, I'm good to go, and not worry about anything else. You say, here's a guideline. I got slippery conditions. I got icy conditions. Instead of 12, I'm going to go 8, or I'm only going to go 6. Whatever you're going to, but you're going to probably sleep better at night when you start changing these numbers and you modify them according to the other things that we've been discussing. So now let's look at curvature of an arch. This really has to do primarily with it helps with your maxillary as well, but it really has a lot to do with the mandibular arch because of mandibular flexure. But it really has a lot to do with your AP spread and what can be advantageous. I thought it was an interesting fact or consideration that a tapered arch propensity of having a greater AP spread because you may have the implant spread out a little bit more. By the way, if you have five implants, don't try to measure through the center of this one. That's your free dessert you got with dinner you didn't expect. That's your bonus implant. Make your measurements out here. That's just going to make you sleep better at night and feel really good about the case, okay? Versus an ovoid arch. But take a look at this. What happens when you get a square arch? You do not have any AP spread. So your cantilever here should almost be nothing other than maybe an attachment coming off that last, say if you did a bar here, maybe you had ERA or something coming off here, but really a cantilever is contraindicated in this scenario based upon what we know about AP spread and the forces of cantilevers. So we're in the home stretch. Now, how are we going to organize all this information that you got going on in your head with your lab, with the implanting surgeon? Oh, wait, I'm wearing both hats. I'm the implanting surgeon, I'm the restorative doctor, with my team members, with the patient. Let's just get into it and let's see how we're going to talk about that. So, what I thought I would do here is I thought I'd dive a little bit into some digital dentistry because isn't that what everybody's wanting to do? And I'm not saying anything bad about it. Don't get me wrong. Okay. So there's no doubt that digital dentistry is really taking us to another level. I just think that sometimes the people get really, hey, it's digital, it's the greatest, it's the best way to go. I think it's a great way to go. But again, I'm trying to get you into an arena of mentality thought process of whether it's a digital, analog, combination thereof, physiological consideration, biomechanical considerations, all these things, how they all tie them all together. So I think that what I've experienced a lot is that people think that I get into digital dentistry, that my level of communication, yeah, that's pretty. I'm just gonna scan it and send it to the lab. I'll just push the send button, it's gone. You actually need a higher level of communication with your laboratory, with your surgeon, implanting surgeon, than I think almost ever before. And I'm going to show you why and see if you agree with me or not. So let's talk about you as a doctor. You're communicating, how you're sharing this team concept information with the implanting surgeon. Okay. Again, prior to surgery, oh my gosh, we haven't placed any implants yet. We haven't made any money yet. We haven't done anything. It's all about the planning process pre-surgically. So, what kind of communication conversations with the implanting surgeon? You're going to want to talk about, doctor implanting surgeon, what pre-surgical records you're going to need from me, the restorative doctor, because if they're doing the digital workflows, maybe they're doing photogrammetry. So the surgeon, if their surgeon's doing the photogrammetry, they're going to know what's going to be needed. We just want to make sure that they're not assuming that you know that what maybe you need to be providing them. Do you need to take the photographs? Do you need them digital? Do you need, how many photographs do you have? Things like that. So make sure that you're talking with them about what do they need from you. And then also very important, now again, I'm looking at you, restorative doctor, as a quarterback here. And sorry, Blake, I'm not able to see your question right there. Catch me at the end, buddy. I'm going to leave some time and I'll try to get to you there. So it's very important to communicate. So I'm looking at you as a restorative doctor, the quarterback again, that you need to make sure, find out what, if you're doing photogrammetry or digital dentistry, what brand, what model even. The model's important. And that share that with the laboratory and the surgeon both so that everyone knows, because labs that are involved with these kind of cases and doing this, they know that they've upgraded to some of the newer scanners and newer software. And I'm sorry, but some of you out there are still on your third generation of things, or I'm sorry to even say it, 5 years old. It could be an antique, but it's important to have this level of communication. Okay. Come on. Why are you not going forward? There we go. Again, it's photogrammetry, what system you're using. Very importantly is this last one that jumped up too quickly on me here, but it's this. How and when will the provisional be fabricated? So this is going to be also important for the patient because as I'm going to share with you, are you going to have that? Is that patient getting a provisional the day of surgery? Now I'm talking about on all on X, of course. All right. pretty much for an all-on X. Because the technology now with our digital, our photogrammetry, and our iOS technologies, our scan bodies, I'm going to share all that with you. They can allow you to either print in office, print a provisional, or patient leaves without any teeth, just healing caps over the MUAs. They've been scanned at the time of surgery. The lab pre-designed a provisional. The lab that day of surgery gets the scans. They can fabricate it that afternoon, that night, overnight it, and the restorative doctor could get the provisional the day after surgery. So you got to know who and how and what is this, how this is all coming together. So photogrammetry, I'm moving a little bit quicker here. I got some more things I want to hit on, but these are just some of the systems, what they look like, popular ones that are out there. Precision iOS, that means that they're scanning indicators that are not just your scan bodies that you do for your crown and bridge. A lot of those are not feasible to use in a full arch, all on X case to use a crown and bridge freestanding scan body. There's not enough geometry, if you will, to capture. So really to do this right, you need to have something like one of these systems. And we work with pretty much any system and we can meet you wherever your workflow is. But you want to know, is it going to be a next day provisional by the lab? Because if that's going to happen, so again, pre-surgically, we're talking about this. Okay, you need to make sure you're talking to your lab to know, hey, what do you need, lab, to be able to have this pre-design done for the day of surgery so that you can deliver a provisional the next day. Don't just assume it can happen because you've heard it happening. You need to zero in with your lab. What can they do? What can't they do? And also with your surgeon. Otherwise, they miss time, they miss cutoff times. It may be 2 days, and that may be to a patient not having teeth for a couple of days. Or are you going to print it in office? That's fine. If you're the restorative doctor or your surgeon's really doing 5-10 arches a month and they have all their equipment in there, again, there's turnaround times. These are the actual scans that a laboratory, from the preliminary scans that they got a week or two before surgery, they designed the smile. Then from the scans the day of surgery, they stitch that all together. This is what they email to whoever's going to print that you send to your printer. Okay. And lastly, the team concept. So what's the minimum required information for the laboratory? And so the lab really still, I think you need to keep them involved with this. 1996, that was when I first started really getting deep into all these things and working on a book and that. But anyways, labs that do these kind of all on X cases, these big cases, they should know also, you should share with them what the patient expectations are. If you can't write it down on a prescription for the lab, what does a patient expect it to look like, feel, and function like, then you don't know it. So it's almost like a test. It's good for the patient, for the lab to know that, but it's also, if you can't write it down, that means you don't know it. You got to pause and say, wait a minute, I got to find out, what do they expect? Because if a lab sees what the expectations are and they see what you sent them and what you're planning on, they could say, hey, wait a minute, doc, this isn't going to work. We need more implants, or we need this, or we need that. We don't have enough bone width or bone length. So labs can help you with this. But again, pre-surgically, get this to them. You'll get more clarity and have less surprises. Also connect your lab to your implanting surgeon. I got to tell you, I lecture to a lot of laboratories, and what I hear from them all the time, I'm never involved in the case till after the implants are placed. Okay, that's a whole nother lecture I give them after they say that to me. But the reality is that does happen. And so if you have a laboratory that you're working with that knows their stuff, they need to be a part of this team. You need to help connect them to the implanting surgeon so that they work together, and the surgeon will appreciate that when they know they have a lab that can really contribute to the long-term success of these cases. So also for the laboratory, you want to have this communication with the lab at least 2 weeks before the planned surgery, because this is where the laboratory is going to start preparing things. They may want to do a test scan with you to make sure that your computer is talking to theirs, or maybe it's the surgeon. Make sure it's their surgeon, their computer is talking to theirs, and so forth. You don't want to find these things out at the day of surgery when the patient's there bleeding and you're doing these things, because if you have a problem, that's called what is that? Oh, a surprise. Okay. We're trying not to have those. So do these things, and I promise you, it's going to be so much nicer, smoother, less stress for you But again, go through this little checklist. It's kind of the same thing that you're asking the surgeon, but you're asking the laboratory because you're all connected at the hip, my friends. You need to speak up. You, the restorative doctor, you need to speak up and tell the surgeon, I'm feeling isolated. Tell me more. Lab, I'm feeling isolated. Tell me more. Okay? So speak up about those things. Also, for the patient, some additional communication. And we talked a lot about the patient, kind of the communication part of it, expectations of it. But here's a part that I think is very important is they got to say a yes. Again, patients aren't going to remember everything you told them. Sometimes they accept treatment and it's 60 days before the surgery actually gets scheduled or things happen or whatever it is. They may forget what was all said. So it's not a bad idea still to remind them about now what stage are we at for surgery. You have this appointment and we have this many appointments and the time frame between appointments. But I got this one here about a resin prototype try-in. Why? Why a resin prototype try-in? I'm going to catch that in a couple slides coming up. But also, very importantly, you want to let them know you're going to set up time with them to evaluate their home care of their provisional because your hygienist needs to see how they've been doing because when you make the new one, it may require, very likely will require a different protocol for cleaning that because during that provisional, it probably didn't adapt perfectly to the tissue and the bones remodeled, tissues remodeled. But now we're tightening everything up in this final prosthesis, tightening that transition line up. We're making this thing, we're not getting food packed underneath it. So they may have to be taught a new way to take care of it. So why do a resin prototype try-in? So it's really to verify. Now you have those picky patients aesthetically, they're just driving you crazy, if you will. This is when you want to do that for sure. And I like a printed one because the patient can actually wear it, but you're going to be able to verify the aesthetics, phonetics, because if maybe you were changing vertical, a lot of times there's a lot of muscle reprogram that needs to take place. Tongue's going to also change shape when you make more room or you have less room. Different things like that can affect speech. And just how does it look to the provisional? Because when you do the prototype, you'd already done a scan to get the tissue, pick up that new tissue, the healed tissue, if you will. Okay. But also take a close look at this particular case. Look at you notice anything on this case? Okay. Notice a little notch out of the incisal ledge. Okay. What this case is, it was used with a straight abutment instead of an angled. The implant was placed straight and it needed a 17-degree angle correcting abutment, or maybe one of the angled screw access hole abutments, which could be enough to maybe take care of this. Either way, it needed some attention. But if you didn't do this, and if the lab really wasn't on their toes, and this comes out and the patient gets that in a final, that's not going to be a good thing at all. So it also gives the patient that test drive. They can wear this provisional for a couple of weeks, make sure they're happy with it, their spouse is happy, their friends are happy. For a little extra cost, the laboratory, they can stain them. They look very nice and they can wear that before you go to the final. So not a bad thing to do. And I don't think it's utilized enough. If you're working with our labs, you're going to find a lot of labs are going to probably push you a bit to do this test drive because it's a very important part of the process. We want to make sure that occlusal scheme is worked out, fine-tuned out here, because you're not going to want to do that on your milled zirconia restoration that's been stained and glazed, and now you're going to go in and adjust the occlusion. No, you don't want to do that. You want all that worked out right here, okay? It's the highest level type of dentistry that we're doing, other than getting into facial reconstruction or trauma type cases. But when it comes to dentistry, this is the highest level, and it requires skill, knowledge, care, time, good team working together to make sure that you're meeting the patient's expectation because we're all here for the patient. If not, we wouldn't be here, right? So wrapping things up here, if the patient was happy with the provisional and didn't have any changes, you could literally just email the lab and say, hey, go to the final. Or if there's any other changes, take some pictures of it. Minor changes, the lab could just go right to a final and make those changes. Wonderful type of dentistry to be doing. What a great service for a patient. And for some patients, it's their only option to really give them back a quality of life. And so let's wrap up with the final part about the delivery of a few slides left here. And so this could be then the third restorative appointment. It could be the second restorative appointment. Maybe you were doing a lower and everything was fine, or you know that everything is fine. It's your call. I'm just saying that it's the reasons that you would do a resin prototype try-in. I think I pretty much beat that one pretty good with a stick. That it's going to make sure the patient gets buy-in and sign off on it, okay? Because once these are done, the only other thing to do, you don't go relining, adding porcelain to a zirconia restoration. It doesn't happen. You get a whole new restoration. Okay. So delivery of that final on the third appointment. It's just so impressive what labs can do with this, how beautiful these pucks are, multi-layer zirconia cuts, pucks, night guards, really. You just got to really get the patient the what's in it for me, the with them. Remember, I talked to you about that, the stress, three types of force, shearing forces are the most detrimental. That's what happens when sometimes these patients get clenching at night. They don't have periodontal ligament. They don't have the proprioception of that they're contacting. Think about it. You folks that have natural dentition or crown and bridge, but even so, you can feel a hair between your teeth, between the enamel of your teeth. You can feel a hair. It's what, 75, 100 microns? You can feel that. And so that's because you have the proprioception. But when you edentulate a patient, you put implants in, they lose a big portion of that. So we have to help set them up for success as opposed to setting them up for failure. Because it's still going to come back to you if this fails and they're going to want something fixed. Now you're going to be in a whole situation of who's going to eat what, who's going to pay for what. Oh, you got an attorney involved? Okay, now I'll go ahead and do all that. Folks, don't cut corners. Don't be tempted to cut corners. Don't get in the price war. If someone's not willing to pay your price for what you need, that you know you needed for whatever type of dentistry you're doing, they're not your patients. There's more of them out there. Please, I've seen it happen. I've heard stories from clinicians for years and years. It's no different today than it was 20, 30 years ago. It's the same thing. Okay. Home care training, also on the third appointment. Patients real excited. They also want to show off their final. And the hygienist, they saw them during the integration period and the provisional. You should have had them come in and check their home care. But now they may need to be retrained on how to use maybe different instruments, different tools, how to hold the water pick differently to get access, how to use a floss threader they didn't use before, different things. But you need to have that time and get them comfortable with that because without that, not going to meet their expectations. This book, Susan Wingrove, longtime dear friend of mine, she is to me, one of the most clinical, savvy, data conscious, analytical nerd person of hygiene when it comes to implant dentistry. And this book is second edition and it's a must have. Your hygienist will love you for it.